My name's Dominic Power. I'm a consultant hand and peripheral nerve surgeon and one of the editors for Orthoracal Hand, Wrist and Peripheral Nerve. This short talk is about carpal tunnel syndrome. Carpal tunnel syndrome is the most commonly encountered entrapment neuropathy affecting peripheral nerves. It affects the median nerve at the wrist, and the median nerve passes through the carpal canal under the flexor retinaculum and then supplies the palmar radial aspect of the hand and digits. A small area over the thenar area is supplied by the palmar branch of the median nerve and is usually spared in carpal tunnel syndrome. Carpal tunnel usually starts as an ischemic intermittent event affecting a peripheral nerve. Intermittent symptoms of paresthesia. This can often cause waking from sleep. Patients typically report nighttime disturbance and waking up with tingling in the hand, alleviated by dependency and shaking the hand and fingers. In the later stages, there is disruption of the nerve and blood vessel interface with edema within the nerve and disruption of conduction within the large myelinated fibres. And this causes more protracted, more severe symptoms and some pain. Left untreated, there can be segmental demyelination from the area of pressure overlying the nerve, and eventually there can be disruption of axon continuity within both the large sensory fibres for pain and temperature and also for the motor fibres, resulting in some thenar muscle wasting. So I typically break down carpal tunnel into three clinical stages. The first is intermittent symptoms of paresthesia or tingling, the second, more persistent numbness, and the third, significant permanent numbness associated usually with wasting of the thenar muscles and restriction of delicate thumb movements. The clinical diagnosis is based on the history followed by a thorough clinical examination. Normally, pressure over the nerve at the wrist crease with the wrist in a flex position can precipitate the symptoms. And Tinel sign, so tapping over the median nerve at the wrist, can invoke sensory symptoms that are unpleasant tingling in the distribution of the median nerve. If there's thenar wasting, then usually nerve conduction studies demonstrate slowing of motor conduction velocity or even absence, and needle sampling of the thenar muscles reveals evidence of chronic denervation and loss of motor unit potentials. The treatment for carpal tunnel in the early phase is symptomatic alleviation using splints. Steroid injections have shown some benefit, though in patients with stage 2 carpal tunnel, 40% of patients in a longitudinal study still required surgical decompression by 12 months. In patients with severe stage 3, I do a functional assessment to ensure that the CMCJ of the thumb is mobile and not arthritic, and then I consider doing an opposition tendon reconstruction if this is a functional requirement for the patient, as well as a carpal tunnel release. I perform carpal tunnel surgery under local anaesthetic with a tourniquet applied around the forearm. There are alternative techniques including wide awake, local anaesthesia, no tourniquet, and in revision cases or complex cases where I expect to find some pathology within the carpal tunnel, such as chronic tenosynovitis, then I may elect to use a regional anaesthetic block. Personally, I don't advocate an endoscopic technique for carpal tunnel, and the reason for this is as a peripheral nerve surgeon, I have to deal with the consequences of nerve injury, and there is a steep learning curve. The advantages of endoscopic decompression are perhaps an earlier return to work when bilateral decompressions are performed in one sitting. In my experience, the results of open are perfectly adequate. The surgery is performed by releasing the skin, the palmar aponeurosis, and then incising the flexor retinaculum throughout its length. And I take great care to release the distal antebrachial fascia into the forearm for about 15 millimeters. And my distal release is as far as the superficial palmar arch. I inspect the nerve, and if the nerve is tethered or stuck on the undersurface of the flexor retinaculum, I perform a limited external neurolysis. The wound is closed with simple interrupted sutures, a bulky dressing is applied, and the patient's encouraged to mobilize their fingers, with elevation advised for the first 48 hours to minimize wound swelling, pain, and complications at the wound. The results are pretty good. About 95% of patients who are selected well have excellent recovery. But there are situations where patients don't progress well, And sometimes this can be managing expectations. If the patient has very severe carpal tunnel decompression, perhaps on release their expectations are not met. I deal with a lot of failed carpal tunnel surgery referred into our unit, and I consider failures to be either a bad diagnosis, so there may be something that better explains the symptoms, a bad nerve, so the patient's expectations weren't met but the nerve didn't have functional recovery potential and surgery was just undertaken to prevent deterioration, a bad operation, so occasionally we see incomplete release of the nerve or nerve injuries, and bad luck. So occasionally patients can have disproportionate responses to pain following decompression of a severely entrapped nerve, or they can develop pain syndrome such as complex regional pain syndrome, but this is pretty rare. So in primary carpal tunnel, I believe open decompression is the simple procedure of choice. Occasionally patients require slightly more extensive operations, particularly if there's synovitis around the flexor tendons or chronic tenosynovial proliferation restricting finger movements. In such cases, I prefer to do primary surgery with a tourniquet and a regional anaesthetic block to allow time to that more extensive release. In revision cases where the nerve is tethered or stuck, I do a neurolysis. I always do this under a regional anaesthetic block, and I consider using an adjunctive barrier around the nerve to try and prevent it scarring again. My preferred barrier method is to use an Axoguard. This is a collagen wrap that's derived from porcine extracellular matrix. This is a layered open weave structure that allows rapid revascularization, and it can be coiled around the nerve. It's available in a number of diameters and lengths, but a typical one for a female carpal tunnel revision surgery would be 7mm diameter by 40mm length, or for a male 10mm diameter by 40mm length. I suture it to itself and then I close the wound. What happens is this layer rapidly revascularizes, restoring the paraneural tissues, or the mesoneurium as it's termed, which is the vascular gliding layer around the nerve. It minimizes the risk of neurosthenalgia or nerve tether following revision surgery. In my hands, I've been very happy with the results of using an Axoguard nerve wrap in revision nerve surgery cases, and it's rapidly become my treatment of choice.